Hello everyone, in this video we're going to be looking at the innervation of the thoracic and abdominal viscera section of the course pack. This resource is brought to you by the Scrubs team, which is the Student Collaborative Resources for Understanding and Brody Success. My name is Bryce Pugh and I'm in the class of 2027. So let's start with the Scrubs mission statement. Scrubs is a student-driven initiative that aims to develop supplemental resources for current and future cohorts that will pass through Brody. Members of Scrubs participate in a variety of subcommittees working to create resources for students by students. These resources aim to offer a unique perspective from students that have walked in the same shoes, developing resources that we wish we'd been exposed to during our time in the course. The hope is that this organization will become a staple of the Brody student body, exemplifying the unique collaborative community that Brody offers. If this is a mission that aligns with your goals and you have the desire to help those that will come behind you, as well as a goal to leave your mark on Brody as a whole, we invite you to join the team. A quick disclaimer before this video starts: the resources that are included in this document are made by students, not the faculty. As such, there's possibility for errors in our development, although this is mitigated via a team approach to development with multiple stages of vetting. If there's a contradiction with the coursework presented within your course, always go by the course documents. Additionally, Scrubs aims to supply supplemental resources. However, these are in no way a replacement to the instruction of the Brody faculty. Use these resources as a supplement, but not as your primary source for course material. So we'll start with some overall innervation and begin by looking at the thorax, and then we're going to move on to the abdomen later on in the video. So when looking at all of the innervation in this video, we want to be thinking autonomic. So we're going to be innervating our viscera, and this is all going to be visceral because if you think about it, you're not going to actively be controlling your heart or your GI tract digesting something or your lungs. These are going to be things that are automatically going to be happening in our body. So we're going to be all autonomic. We also want to get familiar with the term plexus and all these plexuses because this is going to contrast like the upper limb section or the head and neck, because a lot of times there we're just going to see one nerve going and going to a muscle or something like that. But here in the abdomen and thorax, we're going to see a lot of plexuses. And these are going to be because all of our branches are going to have all these complex, tiny connecting branches, communicating branches. And so it's going to be really complex. And so rather than looking at all of these individual little branches, we want to just get familiar with having a plexus that innervates something. And so we'll see that a lot. And when looking at autonomic, we're going to then further divide into two components. We're going to have parasympathetic and sympathetic. And we've seen a lot of this already, but just to recap, parasympathetic is going to be our rest and digest function. Sympathetic is going to be our fight or flight, and that's going to be, I like to think of it as if a bear were chasing you. So when trying to think of what's going to happen when we get sympathetic activation, I think if a bear is chasing me, what is my body going to do? And we'll come back to that later. But parasympathetic, this is for the most part going to be entirely vagus. So our vagus nerve is going to be the master of rest and digest, the master of parasympathetic. So whenever you see one of these, your first thought should be to connect the two. Also with parasympathetic, we want to be thinking preganglionic for the most part, because our parasympathetics are going to come off, and if you think back to Unit 1, we're going to come off and give long preganglionic that are a lot of times going to go down to our viscera, synapse in the walls of the viscera, and then give off a little branch that's going to innervate that. And so we want to be thinking preganglionic for the most part as we go through this video. Sympathetic, on the other hand, for the most part, is going to be postganglionic. And this is going to be because our sympathetic branches are going to come off our spinal cord, and they're first going to go into our sympathetic trunk. In our sympathetic trunk, we're going to either synapse right away, or sometimes we'll move up a little or down a little and then go. But anytime we're looking at the viscera or the sympathetic components throughout the body, they've already passed through the sympathetic trunk and then gone. So that's why we're going to be postganglionic most of the way from sympathetic components. Looking at our sympathetic trunk, we're going to have our sympathetic trunk that's going here. With the thorax, we're going to be looking at the thoracic spine ganglia, and then in the abdomen, we'll get down to some lumbar and some other stuff. We also want to be looking at our cervical ganglia, which are the uppermost parts, and we're going to have our superior, middle, and inferior cervical ganglia. And so let's start by looking at the innervation of the heart. And so the heart is going to be innervated by the cardiac plexus. The cardiac plexus is going to be, it's going to have two main components really. We're going to have a superficial cardiac plexus and a deep cardiac plexus. The superficial one is going to be kind of tucked under the arch of the aorta in this little pocket here. The deep one will be deep or posterior to that, which will be laid kind of right anterior to the bifurcation of the trachea into the two bronchi. And so we have our superficial cardiac plexus and our deep cardiac plexus. These will be connected via communicating fibers. And so this is another thing that we're going to see. These aren't all going to be so defined as one plexus comes down and goes there. They're all going to kind of connect in some way. Another key component throughout this video is going to be that all the nerves are going to follow vasculature, or a lot of them at least. And so that's why I would recommend watching the vasculature video or reading the vasculature section of the course pack first, as well as the viscera sections, because it's going to give you a good skeleton and a starting place to actually understand what's going on in this section. And so looking at the heart, we're going to be considering sympathetic, parasympathetic, afferent, and efferent. And so we'll start off with parasympathetic. So parasympathetic, we're thinking vagus, and this is rest and digest. So our vagus nerve is going to come down and it's going to split. And we're going to go, one part will go to the superficial cardiac plexus and one part will go to the deep cardiac plexus. And so those will come down and split. Those are both then going to continue on and enter the heart via cervical cardiac branches and thoracic cardiac branches. Those are going to enter the heart and then they will synapse in the walls of the heart and then give off a short postganglionic fiber. So all of this is going to be preganglionic and then synapse in the heart. And so what I just described there, that's going to be our efferent component, our motor component going down to the heart. We're also going to have afferent or afferent, so our sensory component. And if we remember back to the vagus section of the head and neck, we're going to have our inferior ganglion, which will be where the GVA's components are going to synapse. And so we have our sensory components coming up, synapsing in the inferior ganglion and going back up to the brain. With our sympathetic components, we're going to be thinking about our sympathetic trunk. And so we have our cervical ganglia and our thoracic ganglia of the sympathetic trunk. Our cervical ganglia, we have our superior, middle, and inferior branches. They're going to give off these cervical cardiac branches. So cervical ganglia to the heart, cervical cardiac branches. They're going to come down and go down to the heart. And these are all going to be efferent. So these are all just giving motor components. Moving down to our lower sympathetic trunk, so our thoracic ganglia, we're going to be innervated by T1 through T5. And these are all going to give off thoracic cardiac branches. So from our thorax to our heart, thoracic cardiac branches, which are then going to innervate the heart. And these are all going to be efferent motor innervation, but we're also going to have afferent sensory innervation. And so that's going to have a different ganglia because remember, when looking at the spinal cord, our sensory components are going to enter the spinal cord posteriorly. So the sensory are going to kind of follow the same path, but then they're going to enter via the posterior root ganglia, which is where they synapse. And so thinking of stimulation, so when one of these gets activated, and I also want to point out this cartoon kind of has them all separated into the different components, but really when we look at what's actually happening and look at the actual nerves, they're all kind of meshed together in this plexus. And so this is just defining the different sections and innervations that we get, but in the real thing, it's all just meshed together into the cardiac plexus. And so back to thinking of stimulation. So if we have sympathetic stimulation, so if a bear starts chasing you, what's going to happen? Well, if we're running, our heart rate is going to increase and the contraction strength is going to increase of our heart. So we want to be contracting a lot of blood and our heart rate is going to increase. And this is going to be from our atrial plexuses. We're also going to have our coronary arteries dilating because we want a lot more blood, a lot more demand for oxygen throughout our body and our heart. And so we want dilation of the vessels so we can carry more blood through that. And that's going to be done via the coronary plexuses. If we get parasympathetic activation, so the bear stops chasing us, a few hours pass, we go lay down, eat a little bit, go to sleep, then we're going to have the opposite effects of all of that. Heart rate decrease, lower contraction strength, stuff like that. Now moving on to innervation of the lungs. This is going to be similar. We're going to have GVE components, GVA components, sympathetic, parasympathetic to look at, but we're going to be a little bit different here. So we're going to have our pulmonary plexus innervating our lungs. So we had our cardiac plexus for the heart, pulmonary plexus for the lungs. And the pulmonary plexus is going to be made up of an anterior and posterior plexus, similar to the heart with two different parts. And those are going to be defined based on where they run in relation to the roots of the lungs. So the anterior pulmonary plexus, as you can imagine, will run anteriorly to the root of the lungs, and it's actually going to be a subsidiary of the deep cardiac plexus. So we talked about the deep cardiac plexus kind of overlaying the bifurcation of the trachea here. That's going to be the same region as our anterior pulmonary plexus, which overlays it. So those are all kind of intertwined there. Our posterior pulmonary plexus is going to run behind the trachea. So we can see that here. Our anterior one is going to be right here. The posterior is going to be running behind it. And you can see some nerves coming up behind it. And so looking at what we actually have here, same thing, we're going to have sympathetic, parasympathetic. So our parasympathetic, rest and digest, vagus. Vagus is going to come down, and again, we're preganglionic until we actually get to the lung, and then we're going to synapse and give off a short branch to innervate it. But these are going to be our thoracic branches of the vagus still. We also, going to the other side now, we're going to have sympathetic innervation. And so this we want to be thinking sympathetic trunk. The sympathetic trunk components that go to the lung are almost the same. We're going to have T1 through T6 this time, so one more. And we no longer have our cervical ganglia. So T1 through T6 are going to give off the thoracic branches, and those are going to go to the lungs. And so this is going to sound really familiar. A lot of the terms kind of start to overlap, but again, remember these are all kind of intertwining and connecting, so our thoracic branches. We also are going to have our cardiac plexus carrying sympathetic and parasympathetic components down into this as well. And we talked about that a little bit here. And so same thing, thinking stimulation, what happens if one of these gets activated? So if our parasympathetic is activated, we're just laying at home, breathing, using our lungs. What's going to happen when this is activated, our vagus, then we're going to get bronchoconstriction and increased mucus secretion. And so if we're just relaxing, we're not breathing super hard. We don't need to have super dilated lungs where we can accept maximum amount of air. We can constrict and have less air coming in when we breathe. And then, of course, sympathetic is just going to do the opposite of parasympathetic. And so next, the last one in our thoracic plexuses, we're going to have our esophageal plexus. And this, as you can imagine, is going to be overlaying the esophagus. And so this, same thing, we're going to have sympathetic, parasympathetic, GVA, GVE. And this you should be able to look at in lab. It'd be really good. We're, for the most part, going to get innervation from the vagus. But again, we still have some sympathetic innervation as well. So looking at what's going on here, we have our vagus, right and left vagus, come down and hit the inferior 2/3 of the esophagus right here. And then they're going to become plexiform. And they're going to continue on. And then once they get to the bottom, they're going to give off two vagal trunks, which are going to be, one is going to be anterior and one's going to be posterior to it. And so they're pretty much continuous, even though they're plexiform. Our left vagus is going to become anterior, and our right vagus is going to become posterior. And this is due to the way that the stomach develops embryologically. It's going to sort of rotate, and that's going to force the left vagus to kind of become anterior to that. And so continuing down to the abdomen, we'll then have our anterior and posterior vagal trunks. Looking at our plexus, so we do get a contribution from our vagus, but we're also going to get contribution from our sympathetic trunk. And so this one, our esophagus runs all the way down, so we're going to get a lot from a different spot. So we're going to get T1 all the way down to T10, and that's going to be GVA and GVE, so sensory and motor, T1 through T10. With our vagus, we're not actually going to synapse here. So we want our vagal trunks to keep going down to our abdomen. So we're going to be preganglionic here and then continue as our vagal trunks. And we'll revisit those as we go into the abdomen. And so to do a quick summary before we move into the abdomen, for our thorax, let's look at our heart first. So we have our heart sympathetic contribution will be from cervical ganglia as well as T1 through T5. And these will be postganglionic. Parasympathetic innervation will be vagus. So parasympathetic, vagus, vagus, vagus. Vagus, we're going to give cervical and thoracic branches to our heart. Lungs, sympathetic, we're going to think cardiac plexus is going to bring the sympathetics, as well as T1 through T6. Parasympathetic, we have vagus, vagus, vagus. We're going to get cardiac plexus branches and thoracic branches. Esophagus, our sympathetic innervation is going to be T1 through T10, sympathetic trunk. Parasympathetic, vagus, 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 vagus. Always think vagus for parasympathetic, especially for the thorax. Okay, now let's move on to the abdominal viscera. So our abdominal innervation, it's going to seem pretty daunting at first. This is a complex picture, but we're going to go through all the different parts of it. And there are a few other pictures you can look at that kind of simplify the different parts, but this kind of connects it all together for me at least. And so looking at our abdominal innervation, we move down into the abdomen and we're going to have our aorta, our big aorta, and a lot of the nerves are just going to run down the aorta. So we're going to have a lot of aortic plexuses. And then, like we mentioned, a lot of the branches are going to follow vasculature. So we're going to have a lot of nerve branches that are going to follow vasculature branches of the aorta. And this is again why it's really helpful to know the vasculature first, because then you can have this skeleton to overlay all the nerves on. And so kind of a general overview before we really move into all the different parts. Sympathetic innervation of our abdomen, or of our abdominal viscera, we're going to see this new concept of splanchnic nerves, and this is going to be preganglionic sympathetic. So remember, usually our sympathetic, in the thorax at least, we would synapse first in the sympathetic trunk, and then go to our effector structure. But here, we're going to have some preganglionic sympathetic that's going to have long preganglionic, and these are splanchnic, and so we'll look at some of these here. So the main ones that we want to consider are going to be our thoracic splanchnic nerves, and we're going to have a greater, lesser, and least, and those are going to be, as you can imagine, a little higher up for thoracic. And then we're also going to have lumbar splanchnic, and so those are going to be coming off of our lumbar spines. The thoracic ones, these are going to be coming off of the intermediolateral cell column. And so if you might want to look back at the spinal cord, where we have our intermediolateral cell column in that. And so we're going to be looking at T5 through T12 for that. And so our sympathetic components for all of our abdominal innervation are going to synapse in plexuses. And then the postganglionic branch after that is going to follow our aortic branches, or our vasculature. Our parasympathetic is going to be preganglionic. And this, again, still parasympathetic, we're going to be thinking vagus, vagus, vagus almost all the time. So here's where we're going to start to see some exceptions to that, is going to be with splanchnic. So splanchnic is going to be all of our weird exceptions. And so with our parasympathetic, we have pelvic splanchnic, which we'll get to down here. And that's going to be coming from S2 to S4 spinal regions. And so our parasympathetics are going to synapse in the visceral walls. And so these, looking at all of our viscera, they're going to travel to the viscera, then synapse, and go off in the walls. And this is the same like with what we saw with the thorax. And then sensory components, these aren't going to be as much of a thought in here, but they're for the most part just going to travel with the parasympathetic and sympathetic components. So let's start looking at some of our plexuses on the aorta. And so looking at our aorta, this is kind of the cutoff where we pass through the diaphragm and become the abdominal aorta. And this is going to be at the T12 region. And that's going to travel down all the way to the L3 region, which is going to be about here. And so we're going to have a lot of plexuses around this region. And so they're typically going to be named for their associated arterial branch. And so the first one that we're going to look at is going to be the celiac ganglion, or the celiac plexus. And this is going to be right adjacent to our celiac trunk that comes off anteriorly. And so just to kind of explain this drawing a little more, we have parasympathetics in yellow and our sympathetics in green, and I kind of split it and did half on one side, half on the other, but keep in mind these are going to be both sides. And you can see that here, like that and that are the same. These are both the celiac. And so our celiac plexus is going to receive sympathetic innervation from our greater splanchnic nerves. And our greater splanchnic nerves are going to be contributed to by T5 through T9 of our sympathetic trunk. So those are going to come down here, and most of them are going to synapse in the celiac plexus, but some of the fibers are going to continue down into more lateral or inferior ganglia all throughout here, and synapse then. And so one that we want to look at here is going to be synapsing in our suprarenal gland. And so they can synapse directly in the chromaffin cells of the medulla of our suprarenal gland, is one of the things for the greater splanchnic nerves. Now looking still at the celiac plexus, we get parasympathetic innervation. So parasympathetic, we want to think vagus. Our vagus is going to come down. We already talked about we're going to split into anterior and posterior trunks. Our anterior vagal trunk is going to bypass the celiac plexus and distribute directly to the stomach, duodenum, and some other stuff. So our anterior trunk, you can see, is just going to come off and go to the stuff. Our posterior vagal trunk is going to come down and pass through the plexus, but it's not going to synapse, and it's going to go to the same organs like the stomach and duodenum and stuff. And so this doesn't perfectly show it, but our anterior trunk is going to give some sympathetic contribution to our celiac plexus, and then just go straight to these. And so here's just some other pictures to kind of reiterate this idea. We have our green as our parasympathetic, our yellow as our sympathetic. And so we have, you can see our splanchnic nerves are coming off here and coming to our celiac ganglion here and our celiac plexus. And then same thing over here. We have our vagal trunk coming down. Our anterior is going to kind of just directly go to our stomach or wherever it's going, whereas our posterior is going to come down and pass through the celiac plexus to continue on down to all of this. And you can see how intricate all of this is. They're all connected in crazy ways. Continuing with some of our aortic plexuses, the next one that we're going to look at is going to be our aorticorenal plexus. And this can be found in the drawing right here or right here. And so it's going to be found next to our renal arteries. So hence the name a little bit, aorticorenal renal arteries. And the plexus is on the aorta, so that gives it the name aorta, renal, aorticorenal. And so we're going to get preganglionic sympathetic fibers. So that's going to be from over here, from our lesser splanchnic nerves. And that's going to be contributed to by T10 and T11. So those are going to come give off the lesser splanchnic, which synapses at the aorticorenal. We're also going to get some contribution from our least splanchnic nerve, which is coming from T12. So our least splanchnic nerve is going to go, it's going to synapse in our renal plexus as well as our aorticorenal plexus. And so aorticorenal, lesser, and least splanchnic. Our parasympathetic innervation to our aorticorenal plexus is going to be coming from preganglionic vagal trunks from our celiac plexus. And so we saw the posterior one is going to pass through that and continue down. One of the branches is going to come over to our aorticorenal, as well as our renal, but that's more of a minor one. The next plexus that we want to look at here is going to be our intermesenteric plexus. And so it's named because it lies between our superior mesenteric artery and our inferior mesenteric artery. And so the intermesenteric plexus is going to lie right here. Our intermesenteric plexus is going to get preganglionic sympathetic fibers from L1 and L2. So we can see here L1 and L2 is going to give our upper lumbar splanchnic nerve that's going to come and synapse there. We're going to get preganglionic parasympathetic fibers from our vagal nerve. So parasympathetic, think of vagus, it's going to come down here, and this is going to be the most distal extent of our vagal innervation. So this is kind of the last hoorah for our vagus nerve. So it goes all the way down to here, and it's going to synapse. And you can see that coming. And then this is going to just go to supply the large intestine at the left colic flexure, which is also our splenic flexure. And so here's just another picture, again, reiterating that idea. We have our lesser and least splanchnic nerves coming down here, as well as our aortico-renal ganglion pictured here. And our intermesenteric plexus is going to be a little far down. It's going to be between our inferior mesenteric artery and our superior mesenteric artery. The next plexus that we want to look at is going to be our inferior mesenteric plexus. And so that, you can guess, is going to be inferior to our mesenteric artery. So our inferior mesenteric artery, we go down a little bit, we hit our inferior mesenteric plexus. Our inferior mesenteric plexus is going to get preganglionic parasympathetic innervation from our pelvic splanchnic nerves. And so we can see that just kind of getting traced all over the place. But our pelvic splanchnic nerves are kind of going to be this weird exception coming down here. And so the pelvic splanchnic nerves are going to come off of S2 to S4, and they're going to be traveling up kind of this opposite direction. They're going to go up, and they're going to pass through the hypogastric nerve, which is pictured on this side, but it's going to go through the hypogastric nerve, and that's going to be how we're going to get to the inferior mesenteric plexus. We also want to look at our lower two lumbar splanchnic nerves. And so you can see that here. Those are going to be coming from L3, L4, and L1 and L2. And so it's going to be this weird connection, but they're going to be formed by L1 and L2, and they're going to exit the sympathetic trunk at L3 and L4. So it's going to be formed here, come down one, and then exit out. And so that's our lower two lumbar splanchnic nerves. They're going to pass through the superior hypogastric plexus, which isn't as important for us, but it's going to then travel up through here to get to the inferior mesenteric plexus. And this is technically not part of our aortic plexus just because it's so low down. And so now, just to kind of get a summary of these abdominal plexuses. So we looked at a summary of the thorax, now we're going to get a summary here. So these are going to be the important plexuses that we looked at. We have celiac, its sympathetic contributions, our parasympathetic contributions, aortico-renal and renal, intermesenteric, inferior mesenteric, and our superior hypogastric. And so this is kind of the full names of what you need to know. Here I made a table that's more of a simpler one, and you can kind of piece together what we've got. And so looking at these, parasympathetic, we have vagus, 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 pelvic, splenic for inferior mesenteric, and superior hypogastric. So our lowermost two will get innervation from the pelvic splanchnic for parasympathetic. Sympathetic, moving down this list, we have our greater splanchnic, lesser splanchnic, least splanchnic, upper lumbar splanchnic, and then lower lumbar splanchnic. And so to give an overall summary, just kind of recapping what we've talked about, we want to keep in mind that nerves are going to travel with vessels, and so that's going to oftentimes give you a good indication of the name of the artery or the vessel, vice versa. And we also want to think preganglionic, sympathetic, or splanchnic nerves are usually going to synapse on the ganglion in the aortic plexuses. So preganglionic sympathetic is going to synapse in plexuses and then distribute along with the vessels. Our preganglionic parasympathetic are typically going to synapse in the walls of organs. And we saw that all throughout this video. Our parasympathetic for the most part, are synapsing at the walls of organs. And so to end this video, let's look at some clinical anatomy. And so a couple brief ones and then one really important one. So peristalsis, which is just kind of contracting of the GI tract to pass food through as it gets digested. Peristalsis of the GI tract is controlled by parasympathetic fibers. And this makes sense because peristalsis is one of the major components of digestion. And so parasympathetic, our rest and digest, is going to be powering our digestion here. Vagal parasympathetic fibers are going to stimulate acid secretion. So looking at our stomach, we have parietal cells, and those are going to be what secrete the acid to break down food and stuff like that. And so that's going to be stimulated by our vagal parasympathetic. So stomach, digestion, parasympathetic, vagus, that's going to happen. And so this becomes clinically relevant because if someone gets a peptic ulcer, then that can be treated somewhat by getting transection of the vagal trunks, and that'll reduce this kind of excess acid buildup that results as with peptic ulcers. And then the main one, this is probably, I would say, one of the most important topics of this whole chapter, and that's going to be referred pain. And so pain in our viscera, visceral pain in our organs and stuff like that, then that's going to travel back to the spinal cord via this, like a reverse of the sympathetic pathway. And so the way that we got to that viscera on the sympathetic nerves, we're going to travel back that way really quick to the spinal cord. And then we're going to go to the spinal cord at the segment that is going to be supplying neurons for a different part of the body. And so this gives us this idea of referred pain. And so here's a quick definition of it, but this is going to be pain from viscera that gets perceived as coming from some somatic body or some dermatome of the same spinal cord segment. And so we saw that if we get visceral pain, it's going to run back to the spine, and then the region of the body that that spine supplies is going to be is where you're going to feel pain, and that's referred pain. And so this can also kind of help us pattern the map of dermatomes. But a few important examples that we really want to know these well is going to be heart pain. So if you have heart pain, you are not going to be able to feel it in your heart necessarily. A lot of times it's going to be felt as referred pain. And so this is going to be heart pain. If we get pain in our heart, sensory fibers are going to accompany cervical and thoracic cardiac sympathetic nerves. And so we saw that was the sympathetic contribution. And so that was coming from T1 through T5. So the pain goes back up through there. And then the spaces that we're going to feel that at is going to be the first and fifth intercostal spaces, as well as our medial upper limb. So that's going to be seen in blue here. So this is heart pain will be felt here. Gallbladder pain, it's going to enter the spinal cord at T7 through T9. And then that's going to be felt at the 7th through 9th intercostal space. So gallbladder, it shows it here, but that's going to be here. So gallbladder, mostly going to be here. It can also be felt in the shoulder at times. The appendix, if we get pain in the appendix, that's going to enter the spinal cord, go back and enter the spinal cord at T10 through T11. And this is going to be felt as pain in the umbilical region, which can be seen here. And so this referred pain is going to be a really important concept. So make sure you know these three main ones especially, and also just what referred pain is. So gallbladder, appendix, and heart.